Let's Talk About Kidneys takes a deep dive into the chronic kidney disease patient journey. We're here to inspire meaningful conversations and to help people living with CKD gain a full understanding of their disease. In this episode of Let's Talk About Kidneys, Dr. Corpier provides us with the basics of kidney care, early detection of chronic kidney disease, as well as the development of a care plan with your healthcare team. Dr. Corpier, I'm so excited and glad that we're going to be talking about identifying chronic kidney disease early today. Needless to say, I am here to learn. So, what are some of the first early warning signs that a patient may experience?
As far as symptoms, the most common thing is that a patient may experience is maybe swelling, leg swelling is possible. Sometimes patients will see changes in their urine, particularly if they have one of the diseases that causes a large amount of protein in the urine. Then they can see foamy urine, or the urine can look like it's got a head on it, shall we say.
Okay.
And those are two. Occasionally, people will see blood in their urine for certain diseases. The most common thing, though, probably is no symptoms whatsoever. And that's what can make this hard because you can have significant loss of kidney function without feeling a thing. And that will only be detected on laboratory testing. So that can make it hard. And there are different groups of patients, but for patients who are diabetic, for example, their primary care doctors tend to do screening and are nowadays detecting them much earlier than in the past.
Well, and have you ever had a new patient come to you and say, I need a lab test to check my kidney function?
It happens actually all the time.
Really?
There are people that, often it's because they've had a family member who had kidney problems and they really want to be tested, or they've had some other issue that has made them question it, that they decided that they want to be tested. But people come in with that request pretty often, actually.
Very interesting. Well, and I know DNA is really passionate about, is it called keep screening events?
Yes. They're keep screening, and that's the name for them. The National Kidney Foundation sponsors these screenings for early detection of kidney disease, diabetes, and hypertension all over the United States. And so for many years, we have participated. Our director of HR, David Knopp, is very active in putting those together for us, as well as other staff in our practice, and then physicians participate. And so basically they get publicized. Let's say it's at Collin County Community College, for example. This screening is going to be happening on this day, and then we go out there, set up, and are able to screen for protein in the urine, able to screen for blood pressure. And so then we're able to say to people, wow, you need to get this kind of care, or everything looks normal right now, answer their questions. And I think that they're incredibly valuable, not just for the people that you pick up who have problems, but for the awareness.
Yeah, absolutely. Well, and some of the early warning signs that you mentioned could be early warning signs for a multitude of things. How often do you feel chronic kidney disease is misdiagnosed or just missed?
I think that it has what changed in the past. We often, as nephrologists, were referred patients very late, and I know for myself it was very frustrating, and there was almost a grief that I would have about some of the cases, because you're like, if we had gotten to this person a year earlier, 2 years earlier, 5 years earlier, then we could have made a difference in their lives, in their course medically. But what's happened in the last 15 years or so is that now when people get their basic lab screening, they will get what's called an estimated GFR. And so just to boil it down, that is an estimate of kidney function that you can sort of correlate to percentage. So if your estimated GFR is 50, then you have roughly 50% kidney function. And by kidney function, we're talking about how well your kidneys are removing the waste from your bloodstream. Because when we talk about, just to kind of go
Yeah,
back overall, when we talk about kidney failure versus normal kidney function, what we're talking about is this waste management piece.
Mm-hmm.
And so when you think about, or if you do think about, like, what is urine? Okay, I mean, I know it's water, but it doesn't look like my water. It doesn't look like my water. So what's the difference? Well, what urine is it's water with waste, chemical waste from our bodies dissolved in it. And our kidneys are responsible for filtering and adjusting and removing this waste every day. And so when we talk about chronic kidney disease, part of that is, well, what is the level of function? And there are people who have normal waste removal, but do in fact have a disease of their kidneys. If you take my patient Tiffany, who we've talked to, who's a transplant patient now, but her disease, for example, is called IgA nephropathy, and this is a disease that occurs worldwide, and patients can be detected at any stage. And I have patients who have had this detected. They had blood in their urine, protein in their urine, kidney biopsy. It was detected, but they may have had 90% kidney function
Interesting.
at the point that they were diagnosed.
Right.
And so there's this piece of it, which is the waste removal piece.
Mm-hmm.
And the waste removal piece, when that changes and you begin to lose that function, and ultimately when you lose down to 10% or less, then that's when we have to begin dialysis treatments.
I'm so glad you said that, because that was my next question, is what are the options once it's been identified that the kidneys are struggling?
So it depends on when it's identified, and it depends on what the cause is. So, when you first see a patient, these are the things we're trying to figure out. And so we're trying to figure out, okay, what exactly is their function? What has been the trend? Were you normal 2 months ago and now you have 20% function? Or which would be a very rapid progression. Or is this been something that's been kind of sputtering over and gradually changing over the last 10 years? So we're looking at what the trend has been, and then trying to identify what's caused it, and then what we can do about it.
Yeah.
Because for some of these things, for some of the diseases, there's not a specific treatment. There are more general treatments, like certain blood pressure medicines, and we've had a kind of a ginormous breakthrough in the last year or two with a group of medications called SGLT2 inhibitors that came on the market initially for diabetes care, but they've been found to have dramatic impacts on maintaining kidney function, reducing death, reducing cardiovascular events for patients with chronic kidney disease. So whether they have diabetes or not.
Yeah.
So that's been a big change.
So
we have to
options, depending on what they're experiencing. And so what if where would transplantation fit into CKD care management?
So right now, we have Medicare created a benefit several years ago for CKD education for late stage patients, for the stage 4 patients who are people who have kidney function between 15 and 30% of normal. And the reason at that stage was because a large percentage of those will further deteriorate and need dialysis or transplant. So we begin educating below 30. Once the patient's kidney function is at 20% or below, that's the point at which we can refer them for their transplant evaluation. And then depending on whether the patient has a living donor or does not have a living donor, then the patient may be, then you have the option with a living donor of electively scheduling their transplant at the point that they need it. If they don't have a living donor, that's where, the listing and waiting for a transplant comes into play.
Well, and so let's say the decided route, like you mentioned, there's options and there's going to be a certain care management plan, but let's say the decided route is a transplant.
Mhm.
First question first, is transplantation a cure?
No. And of course, that's not what anybody wants to hear. Almost every single patient asks this question, and they don't say cure, but they say, well, can we make it better? And so depending where they are in their course and all of that, the answer is sometimes,
Mm-hmm.
not usually. Often we're left with trying to just maintain.
Mm-hmm.
But in terms of transplantation, so it's important to understand, like, transplantation and dialysis are for people who are either have or are well on their way to losing all of their kidney function. Your kidneys are considered a vital organ, right? And what vital organ means is you can't live without it.
Yeah.
And, mammals don't live without their kidneys
Yeah.
for very long. And so we have to replace this function,
Mm-hmm.
right? And dialysis is one way we do it, and that's another discussion. But for the transplant,
Yeah.
we can replace the function and often get them back to normal function, okay, with a single
Yeah.
kidney. However, when I say it's not a cure,
Yeah.
what I mean by that is that, I think of a cure as, for example, you have a urinary tract infection and you don't have any anatomical abnormalities. You just got infected.
Mm-hmm.
We give you some antibiotics.
Right.
You take them, goes away.
It's like it never
La-di-da.
existed. Yeah.
It's like it never existed.
Right.
Right. With kidney failure, you don't get that luxury.
Right. Yeah, your life will look a little bit different. And
Forever.
we talked about some of those different elements and the factors that are going to be at play.
Mhm.
What are some of the most common misconceptions? It sounds like you kind of touched on a few of them, but is there anything else that comes to mind?
Well, I think with chronic kidney disease in general, there can be a misconception that, oh, well, I'm taking care of myself, so that could never happen to me. That they must have done something, to get that disease, to get that.
Right.
And, again, my patient Tiffany is a kind of the supreme example
Mm-hmm.
of a person who was young and the picture of health, who developed what's admittedly, in the big scheme of things, a rare condition.
Mm-hmm.
But in the kidney world, it's not that rare,
Right.
but it's not something that you bring on yourself.
Yeah.
And for a large number of our patients, most, this is a consequence of sometimes, blood pressure, diabetes, things that or other diseases that sort of come, unfortunately, like a meteor strike.
Yeah. Well, and from what I understand, once the conversation does start about transplantation,
Mhm.
at some point that they may be given several packets to be able to start mailing out and to start that search for the right donor. What expectations would you set with patients? Talked about living donors, so
Mhm.
clearly there's options there as well. But what expectations?
So what we try to say is, or what I do say is, so the first expectation, I guess I should say more clearly, is I explain to them that there's a process here,
Mhm.
and that there's a process to follow, and that process begins with an application. And so you apply to one of the programs, and then they do an evaluation process. I personally have always chosen to view the application process and the evaluation process as identifying anything that's going to be a barrier to your success,
Mhm.
right? It's not like, oh, we're trying to keep you from getting transplanted or to screen you out. That's not what it's about. It's about trying to identify anything that could trip you up.
Mhm.
And then can we deal with it in advance?
Yeah.
And make your transplant, hopefully one transplant that lasts you forever. And that, so I make sure they understand that they're going to go through an evaluation. It's going to involve some number of testing, and the tests vary depending on their other medical conditions. They're going to meet a bunch of people. They're going to meet transplant surgeons, transplant nephrologists, dietitian, social worker. They're going to go through more education. That's going to be the process. It's going to all be presented to a committee that will then make a decision. The decision's going to be, yes, list you for transplant. Wait a minute, we missed something here that we need to look into before we approve you for transplant. And on rare occasion, the answer is going to be no, and that they are entitled to an explanation for the no, and that they also can apply to another program if they get a no.
Okay.
And then we can go over why they got that no. If they believe they have friends and family members, or some people it's church members. I mean, there are all kinds of stories for how people come in contact with a person who ultimately donates a kidney to them, that person will apply. Yeah. And that person will go through their own separate confidential assessment. And then once, if they are compatible, then they, and everything's clear, then they can schedule a transplant.
Moving forward. Well, you touched on this. What is the relationship like, or maybe what are the differences between nephrologists and transplant surgeons?
So they're just two completely different specialties. We're a subspecialty of internal medicine, and they are a subspecialty of surgery. And so our role is in managing the patients before their transplant throughout the spectrum of their time with kidney disease, and then co-manage in the hospital, and then manage them medically after the transplant, really for the duration. So we're doing the medical stuff. I mean, if you have a wound complication, if you have other kinds of surgical complications, the surgeons are going to be dealing with those problems. They are having good surgeons is of course the foundation.
Yeah, absolutely.
You need to have a really good operation to start with.
Well, and following that line around complications, from what I understand, some transplants can last for decades, the rest of your life. Some can fail within 1 to 2 years. Tiffany's, for example, who we spoke with, failed within 8 years. Others can fail within that first week. What are your thoughts around the reasons as to why?
So the early failures are most often, I mean, in this era that we're in, and for decades, really, most often they're technical. They are that there was some problem usually with the surgery at the level of the blood vessel. Usually, there are occasional early failures that are from previously unidentified clotting disorders that were not technical, but the patient's blood system had an abnormality that wasn't detected. Very often these are screened for ahead of time, and so you don't have very many of them. But these are the two most common reasons now. In the early days of transplant, it was from another cause completely. It was something called hyperacute rejection, which basically doesn't happen anymore in America. And when you look at failures, in the first couple of years, then sometimes those are related to rejection or recurrence of the original disease. That's the thing. Acute rejection is part of it, but the medications that we use now are phenomenally successful in suppressing that response. That goes back to making sure you take the medicines.
Right.
As I tell patients, they hardly ever work in the bottle. But once you take them.
That's funny. That's not what I was expecting you to say. I love it.
Well,
yes, no, absolutely true. Absolutely true.
You need a sense of humor to do this job, believe me.
I can imagine. Well, and I'm sure the question comes up then too, can chronic kidney disease still come back within my transplant?
Oh, yeah. Depending on what caused it in the first place, it can come back. And so, for example, I know I keep saying diabetes, but the reason is because diabetes is so common.
Mm-hmm.
I mean, close to half of the people on dialysis, have diabetic kidney disease, somewhere in the 40 to 50% range. So it's very, very common. Yes, diabetes can come back, but usually that is, a 10-year, maybe 8 or 10 years down the road. That's not usually in the first couple of years.
Mm-hmm.
But there are some diseases with funny names, like focal segmental glomerulosclerosis and membranoproliferative glomerulonephritis, and as examples, that can return in the kidney. There are some diseases like polycystic kidney disease, which is the most common congenital cause of end-stage renal disease. I mean, this doesn't come back in a transplant, right?
Yeah.
Because this is an abnormality of the organ, and when you put an organ in from a non-polycystic person, we always do, it doesn't come back.
Gotcha.
So
Yes. It really depends.
we set patient expectations about that too, as well. Like, do you have a thing that has, because there are different rates of recurrence, and so so the more you know about what caused the patient's kidney disease, the more you can kind of set expectations for the patient, but also for the physicians, that what you're looking for afterwards.
Well, in one of the other episodes, we talk a lot about what it looks like post-transplant and the relationship between patient and physician being able to work together. Overall, it sounds like there's a lot of information because there are so many conversations. You hinted at just how many people make up your village of support. There's a lot of information and records that need to be kept up.
Yes.
That's a task. You've mentioned homework, I think, even specifically. So it sounds like being able to track all of that. What do you recommend to patients for being able to keep all of this together and to keep up with it?
The number one thing that I care about is their medication list. Like, it's just, this is just incredible. Like a chef, if you ever watch Top Chef, and the ones that get turned, the ones that have to leave, what you see them is packing up their knives, right? They have their tools of the trade. And in terms of keeping your transplant, this is your toolbox. And so, knowing your medications, having a list of them, like, that's the big thing. And the patients, we don't expect the patients, except those that really want to, and they're usually like engineers, okay, who want to know like every number. You don't have to know every number. I have to know the number, but you don't have to know all the numbers. I mean, you can. We try to teach them, this is where your kidney function is. This is your creatinine. This is what your red cell count. There's certain pieces of the information because it can be overwhelming.
Yeah.
And the whole concept here is that between the doctor-patient relationship, between the staff-patient relationship, is that you reduce anxiety so that people can learn and will approach you when they have questions. And you get much better results that way.
Yeah. Well, and I keep notes in my phone. I use the notepad in my phone somewhat religiously. There's so many to-do lists and things like that are included there. So I can imagine in some cases it's just dropping information in something like that.
Whatever works for you.
Okay, I was going to say, are there recommended, methods for that? But also, it sounds like it's really important to have an understanding of your baselines. That's something that I've heard you talk about a couple of times, is being able to know where you're resting, resting heart rate, and some of those baselines to understand where changes are, so you understand what tools to apply best.
Yeah, I think that for example, because people travel so much, and or because, like, for our patients, they may end up seeing multiple different subspecialists depending on what's going on. It's good for them to know, or if they have to show up in an ER somewhere, it's good for them to know, okay, I know my creatinine, which is the still to this day the test that we use most to track kidney function. I know what my creatinine has been and what it ranges in. So this is not unusual for me. And anything that is a little bit not normal.
Hmm.
It's good for patients to know, if they're anemic, but they're sort of stable at a certain range. It's good for them to know kind of the, these just few things, so that if they, um, like I said, if they come in contact with other providers, that they can, I said, oh, you know,
Yeah.
gets alarmed, or maybe doesn't get alarmed, that the patient can
Yeah.
say, it used to happen a lot with the white blood cell count, like the people on steroids, their white blood cell count tends to run higher. And so then they would get into this whole thing, sometimes with other physicians, sending them in all kinds of
Yeah.
places, or they're anemic and things like that, that we've been following and
Yeah.
have an understanding of why that is.
Encouraged to keep the records.
Yeah, we encourage them to know some things, but again,
Yeah.
really and truly, most everybody would really like to just go through their life and not have to think about these things every single day. And I think that for people with chronic kidney disease, because transplant's not a cure, we're trying to find some middle ground for them, where, I mean, the purpose of your life is not to be a patient.
Mm-hmm. Mm-hmm.
Right. The purpose of your life is whatever it is that you want your life to be. And then we need to keep this thing going
Mm-hmm.
over here. And so, so, I mean, that's the way I look at it.
Absolutely. Well, and I think, a fantastic theme for us to have wrap the episode up on is that preparation and being able to be in tune with yourself, in tune with your body, and because everyone's levels are going to be acceptable for different things. And so being able to just keep track of that as much as you can,
Mhm.
incredibly important. Thank you so much. I think these are fantastic insights. I know I learned some things, so that way I can make sure that for me and those around me are informed.
Well, thank you so much
Yes.
for having us.
Thanks for tuning in today. Learn more about Dallas Nephrology Associates at www.dneph.com. That's DNEPH.com. And if you found the information valuable, be sure to share with those also impacted by chronic kidney disease. Dallas Nephrology Associates DNA podcast series, Let's Talk About Kidneys, is provided for general information purposes only and does not replace the need to talk with a healthcare professional about your unique situation, care, and options. Our goal is to provide you with as much information as possible so you can be as informed as possible. Reference to any specific product, service, entity, or organization does not constitute an endorsement or recommendation by DNA. The views expressed by guests are their own, and their appearance on the program does not imply an endorsement of them or any entity or organization they represent. The views and opinions expressed by DNA employees, contractors, or guests are their own and do not necessarily reflect the views of DNA or any of its representatives. Some of the resources identified in the podcast are links to other websites. These other websites may have differing privacy policies from those of DNA. Please be aware that the internet sites available through these links and the material that you may find there are not under the control of DNA. DNA shall have no responsibility for the accuracy, legality, or content of the external site or subsequent links. Contact the external site for answers to questions regarding its content. The resources included or referenced in the podcast and on the website are provided simply as a service. DNA does not recommend, approve, or endorse any of the content on the linked sites. The content provided on this website and in the podcast is not medical advice and should not be used to evaluate, diagnose, treat, or correct any medical condition. The content is solely intended to educate users regarding chronic kidney disease, end-stage renal disease, ESRD, end-stage kidney disease, ESKD, and related conditions, and ESRD, ESKD treatment options. None of the information provided on this website or referenced in the podcast is substitute for contacting a healthcare professional.